All right. Well, good evening if you're in Europe or other time zones. Good morning and good afternoon to all of you. This is ClassACT 79. We bring together classmates to address issues, and ACT stands for Achieving Change Together. Within our class alone, there are a number of people who are involved in change activities, and the purpose of this is to bring us all together. This was started by ClassACT 73. And now there are at least a half a dozen various class acts. So not only are you part of a community of class of 79 grads, but you're also part of a community of other socially conscious individuals. We're seeking volunteers, ideas for future programs, and we're delighted to have you here today. Use the Q&A function to submit your questions for the panelists. Many of you have submitted questions in advance, and so those will be screened as well. And the chat function is off. So we hope that we have your attention for all of this. And thank you very much for being here. Let me tell you about the panel, which is fantastic. The panel is hosted by two great moderators. So Gilad Gordon is a physician with extensive experience in developing vaccines, including COVID-19, president of the Aura Group, LLC, and is an associate clinical professor of medicine at the University of Colorado School of Medicine.
Gideon Gill is the managing editor at STAT, the media company that focuses on finding and telling compelling stories about health, medicine, and scientific discovery. He oversees its investigative journalism, special projects, and science coverage, including its COVID-19 coverage that was recognized as a finalist for a Pulitzer Prize this year. He joined STAT at its founding in 2015. He previously was the Boston Globe's health and science editor for a decade and was a 2014-2015 Knight Science Journalism Fellow at MIT.
Thanks very much, Dorian, for the introduction. I'm going to introduce the rest of the panelists. We have with us, we're really pleased to have with us today, three of our 1979 classmates. Dr. James Hildreth, he's the president and CEO of Meharry Medical College and a world-renowned HIV infectious disease expert. He has emerged as a respected national figure in the response to COVID-19. In September 2020, he was appointed to the FDA Vaccines and Related Biological Products Advisory Committee, which is the group that advises the FDA on authorizing the COVID-19 vaccines. And in February 2021, Dr. Hildreth was named to President Biden's Health Equity Task Force. Next, we have Heidi Larson, who's director of the Vaccine Confidence Project and professor of Anthropology, Risk and Decision Science at the London School of Hygiene and Tropical Medicine, and clinical professor in the Department of Health Metrics Sciences at the University of Washington in Seattle. Her research focuses on the analysis of social and political factors that affect uptake of health interventions, with a particular interest in risk, rumors, and public trust. Professor Larson previously headed Global Immunization Communication at UNICEF, chaired Gavi's Advocacy Task Force, and served on the WHO, that's the World Health Organization, SAGE Working Group on Vaccine Hesitancy. She's author of Stuck, How Vaccine Rumors Start and Why They Don't Go Away. Finally, we're excited to have Dr. Rachel Levine, who is the 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services, where she focuses on overcoming the COVID-19 pandemic and building a stronger foundation for a healthier future. Dr. Levine's career, first in academic medicine and as a physician, then as Pennsylvania's Physician General, and later as Pennsylvania's Secretary of Health, has focused on the intersection between mental and physical health, often treating children, adolescents, and young adults. We are thrilled to have all of you join us today. And Gilad and I want to start the conversation by focusing on two issues that are front and center now and could threaten the return to near normalcy in the United States. First is the spread of the new Delta variant and its effect on containment of the pandemic. And second is the slowing rate of vaccinations in the US and uneven coverage, with some states about 70% and others with barely 1/3 of their adults vaccinated. Not to mention the abysmal pace of vaccination in most of the rest of the world. So Yesterday, I saw a tweet from Dr. Ashish Jha, who was formerly at Harvard School of Public Health and is now Dean of the Brown School of Public Health. And what he pointed out was that a month ago, the United Kingdom had half the COVID cases per capita as the US. But in the past month, with the Delta variant now predominant there, the case rate has increased sixfold. And the UK's rate of COVID cases is now 5 times the US rate. Hospitalizations are up 80% in that time, though the percentage of fully vaccinated adults is about the same as here. His bottom line was that over the next few weeks in the US, we need to look for a rise in cases, especially in communities with low vaccination rates. So I want to start by asking you, Heidi, since you're in London, what's it look like on the ground there? Are people worried about the this variant? Are they resuming wearing masks? Are they taking other distances measures? Can you give us a sense of that?
Well, aside from a June that feels like winter here, we've which has made, to be honest, it's made mask wearing easier. I have to say, I've been really surprised in a way that mask wearing has become so normalized. I remember a year ago to get anyone to wear a mask, I mean, it was really not. And now, because it's required in all public transportation and to go into a lot of places, it's really become more of a norm. So these things are possible. I think in terms of the current situation with the variant, there are a lot more cases. In fact, even in some, there's a handful of cases, well, more than a handful, that have gotten COVID even after vaccination, but I mean, particularly the Delta variant. But what the assumption is that it probably saved people's lives and they're like less serious illness. So it still has a value. It's not 100% protective, but it's definitely worth getting vaccinated. I think the biggest angst here is this continued delays of lockdown, continued delay of taking back lockdown, because we're hugely restricted in terms of travel, and because of the situation in the UK, it's to go anywhere in Europe. I mean, if you're in Europe and you're doubly vaccinated, you can pretty much go across in and out of countries, no problem, as long as you have evidence of the vaccination. But for UK citizens or people to travel from the UK, in a lot of countries, actually, because of the situation here, has created a lot of frustration. There is an effort to increase vaccination, particularly not unlike the US. There are pockets of unvaccinated groups and the issue of going into younger and younger children. So again, our next level of restrictions are postponed. I mean, we'll stay in them until next month farther, and then we'll see from there. I think it's, yeah, that's the short of it, the long short of it.
Thanks, Heidi. So James, as an immunologist and a real world authority on it, maybe in layman's terms, you can tell us, what is a variant? And why is it important to our discussion? And what makes the Delta variant especially so worrisome? Is it more infectious? Is it more lethal? And then I have a couple of follow-up questions about afterwards.
So thank you for the question. Variants result from mutations that are made when the genome of the virus is copied by the protein called polymerase. So when the nucleotide sequence changes, it can change the amino acid sequence, which can change the shape of the protein. And for the most part, antibodies recognize either individual sequences or the shape of the protein. But every time a mutation is made, there's a chance that a variant will arise. And that's what variants are. They represent mutations that are made when the virus replicates. And by inference, as long as the virus is allowed to spread freely among populations, there's a chance that new variants will arise. And my real worry is that a variant of high consequence is what's in store for us next. The variants we have are variants of concern, And thankfully, the vaccines have some activity against them. But we could end up in a situation where a variant will arise that the vaccines do not cover, and that would be bad news for all of us. But variants represent mutations.
And is the Delta variant, that's the one that's circulating right now, that's the most concerned, is it more infectious, more lethal?
The virus appears to be 60 to 80% more transmissible. And what I think that probably means, and some laboratory investigations confirm this, that the spike protein of the virus binds more tightly to the receptor, which means it takes less virus to cause an infectious event. So the virus is more infectious than the original strains.
I see. And to what extent are the current vaccines effective against the Delta variant? And do some of the vaccines offer better protection than others?
The data that I've been privy to shows that all of the vaccines currently being used in the United States, including in J&J, have activity against the Delta variant. But for those people getting the Moderna and Pfizer vaccines, they need to know that only after you have the complete set of injections, both injections, 2 weeks after the second injection, do you have full protection. But the data are very clear that if you have less than full complement of your shots, you're not fully protected. And I think what we're going to see is what they're seeing in the UK, which is that later in the year, with these large segments of the population not vaccinated, there are going to be surges. They're inevitable, and they're going to happen. So we should be prepared.
So one of the things I've heard, for instance, about the UK is that a lot of them have gotten the AstraZeneca vaccine, and a lot of them have only gotten one shot. So is the UK really a harbinger of what's going to happen here, or is it?
I think in those places where the uptake of vaccines is particularly low, where there's 40% or less of the people vaccinated, that we could well see the same thing happening here that's happening there, because in our case, we have large numbers of people who've not been vaccinated at all. Right? That's the real concern.
Exactly. So do you think we'll eventually need boosters?
It all depends on whether or not we all get vaccinated as quickly as possible. But boosters may well be necessary for variants. In other words, if we keep allowing variants to arise, there may be a variant that we have to get a booster shot for. And the good news is, if there is any good news in this, is that the mRNA technology is very amenable to quickly developing the booster shots. The question is whether or not the FDA will require them to be fully evaluated before they're used.
Great, thank you.
Thanks, James. I want to turn to you now, Rachel, and sort of get the administrations from your position in the Biden administration. How worried are you and your colleagues in the administration about this, about variants overall, but particularly the Delta variant? What are you sending messaging out to governors who are, understandably, they've just opened up their states and their economies, and the last thing they want to do is put in place new restrictions on businesses, and so what are you saying to them, to health departments, your former colleagues in health departments, about this variant?
Well, thank you, Gideon, for that question. So first, I would agree completely with James, is that the evidence shows that the Delta variant is more infectious, more contagious, excuse me, more easily transmissible, and that it is more virulent and can cause more severe disease, leading to more hospitalizations and possibly to more deaths. So we are very concerned about the Delta variant, and we're particularly concerned in states and communities and counties that have very, very low vaccination rates. There is evidence that the Moderna and the Pfizer vaccines are effective against the Delta variant. But as James said, only if you have 2 doses. That is one of the challenges in Great Britain, where they had taken a measure of making sure that as many people as possible got 1 dose, but they're behind in terms of their 2nd dose. We have seen that somewhere in the United States, but 1 dose of any of the vaccines will not necessarily be effective of the AstraZeneca, the Moderna, or the Pfizer against the Delta variant. Johnson & Johnson is currently testing right now to make sure that the Johnson & Johnson vaccine, which I received, is totally effective against the Delta variant, and there's every reason to think so, but some of those studies are still forthcoming. So our efforts are really squarely on increasing our vaccination rates, and that is the result of our month of action that the president called for. So public health authorities, as well as state health authorities and really local stakeholders and community members are really trying to get the message out about the safety of the vaccinations, about how effective they are, and how important they are, especially in the face of this Delta variant. We are starting to see some increases in a couple of states, Missouri in particular, also Oklahoma, where vaccination rates are lower, and we're concerned that is because of spread of this Delta variant.
And in those states, just to follow up, on states like those where the vaccination rates are low, I understand the push to get people vaccinated, but if they're not, what are you saying to those states? Like, what's the next step for them if people aren't getting vaccinated?
I think the next step is to push the vaccinations. You know, there are three ways to address something like COVID-19, a global pandemic. You know, one is containment, which is where we were over a year ago in terms of testing and quarantining and isolating people. The second is mitigation. That's masks, that's closure of schools, closure of businesses. And the third are medical countermeasures, such as the vaccine. We're way beyond containment, although testing is still really, really important. There is very little appetite in the United States right now for mitigation besides mask wearing, but even in many states, particularly in the South, for pushing mask wearing. So I think that it's, of course, this is state by state rules, is very little appetite to close down society again. So I think that where we're going to be pushing our message is getting more and more people, as many people as possible, vaccinated.
Thanks.
Thanks. So a good friend of mine who's a researcher at Penn compared the situation we're now into a hurricane. Some attendees also on the Q&A leading up to our panel discussion raised the same issue, saying that the outer bands have passed through and we're now in the eye of the storm. We're all enjoying, being outside and having meals together. And everything is calm before the follow-on bands hit. Potentially they can be even worse. So to all the panelists, do you agree with this? Will we have a major surge in the United States driven by the Delta variant or potentially another variant and increasing that's even furthered by increasing travel both internationally and locally? And if so, when do you think it will start?
So I wouldn't necessarily call it a hurricane, but I can tell you this. Viruses, RNA viruses, ribonucleic acids, they mutate as a part of their biology to escape our immune system. HIV is a great example. Thankfully, this virus doesn't mutate nearly as fast as it does. But by their very nature, RNA viruses mutate to run away from the response our immune system is making. And as long as there are millions of people out there, in this case, tens of millions of people, there's every chance that a new variant will arise, and it could arise anywhere in the world where there are a large number of people who are not vaccinated. But that affects everyone. So what I'm really afraid of is that the low vaccination rates in this country and the countries that do not have access to vaccines yet are a perfect breeding ground for a new variant that all of us should be afraid of. And it's inevitable that in those states or counties where the vaccine uptake is low, there are going to be surges. It's as simple as that. The biology predicts it. So we should be prepared. So in a sense, I guess that you could think of that as a hurricane. But what I'm saying is the biology predicts that here in the United States and those places where people have not gotten the vaccines in high numbers, we're going to have a problem. It's as simple as that.
When will it start? You have I guess it already has started in Branson, right, Missouri?
Well, there are sports stadiums full of people yelling, shouting. Churches have reopened. Large numbers of people are gathering on the beach. So if you think about the time it takes the virus to replicate, certainly by the end of the summer, early fall is when I think we're going to start to see the problem again.
You know, we've seen a number of different metaphors used for COVID-19. We're often used to the wave metaphor. We had wave 1, wave 2, wave 3, etc. I have liked the forest fire metaphor because, as James was saying, you know, if you're unvaccinated, you're tinder. And tinder in the midst of a forest fire will burn. Where if you're vaccinated, then you're not likely to burn. You're going to be protected. I mean, I think the hurricane metaphor is another potentially useful metaphor. And I think metaphors do help us understand this. I do want to emphasize the progress we've made with vaccinations. In the country, 87% of seniors 65 and older, which is pretty much getting to be us, unfortunately, are vaccinated against COVID-19. And certainly we saw that seniors, particularly those with chronic medical conditions, were the most vulnerable to the virus, most likely to be hospitalized, and tragically most likely to die. 70% of those 30 and older are vaccinated. We expect by the July 4th weekend, which is next weekend, 70% of 27 and older will be vaccinated. We are having challenges with 18 to 26-year-olds. And of course, I'm a adolescent young adult medicine specialist, so this is my age group. You know, I think that young people, as for many things, are somewhat complacent, and they just don't think that they'll suffer the negative consequences, which is clearly not true, which is why we are doing everything we can to get the message out about the safety of the vaccines, to get past vaccine hesitancy, their effectiveness, as we've been discussing, but their importance and how vulnerable you are, that you are essentially tinder in a forest fire if you're not getting vaccinated. I'm a positive and optimistic person. I think that we're going to continue to make progress, both in the United States and in the world, but the risks remain.
Okay. And Heidi, from your perspective, sitting, you know, in an area where maybe we haven't even hit the eye of the storm yet, and the calmness, what is your perspective on when surges are going to recur in Europe or in England?
Well, I'm particularly concerned about Africa, to be honest. It's already, I mean, it's really climbing precipitously, and it has really next to no vaccines. And it's to say that they're going to get them by the end of the year or next year is really, I mean, I think there have been efforts, I know, in the G7 and others, but my worry is we're sitting very, I mean, there's a lot of traffic between Africa and Europe, and already from India, I mean, the Delta variant's coming up there, but I would agree with James very much that my biggest concern is we're going to get, while we're watching Delta, another one's going to come up. And there are many variants happen all the time. I mean, that's why we have a different seasonal flu vaccine every year. But there are ones that are, what do they call them, of interest, and ones that are more of concern, and ones that could really be serious. So I think here they're trying to vaccinate as many as they can, particularly bring it to younger ages. In all of our surveys, and as Rachel pointed out, 18 to 26 has been consistently in most surveys the most reluctant, hesitant group, not just with this vaccine, but in general. And I was just talking with a colleague yesterday, and she was saying we get mass fainting going on now. Fortunately, it's not to the extent of the HPV where they have chronic problems, but you know, it's a kind of anxiety, but it's also, it doesn't matter. And I really appreciate the three domains you mentioned: safety, effectiveness, and importance. Those are the three in our vaccine confidence index. Those are the three key levers. And what's interesting is that while most people will agree to the importance above safety and effectiveness, when you ask, how do you feel about safety, that drops. On the other hand, we see if people don't believe in the importance, you don't even go to safety and effectiveness. So I think for that age group, I think we need to get a number of young people in the room to co-create with us strategies that will reach their peers. That's worked really well in, my favorite example is in Denmark, where they had really some serious anti-sentiment against the HPV vaccine. A group of girls had paralysis and fainting, and but then they brought in a group of young girls of HPV vaccination age and co-created some social media strategies that really turned the situation around. So I think the more we can engage in those ways, it will be important.
Thanks, Heidi. Rachel, what do you say? What about that? Is HHS interested in or adopting strategies like that to target that younger age group?
Absolutely, and we have done that. I mean, there's social media using TikTok and Instagram, and not just going to Facebook and Twitter, but using the social media platforms that young people do. We have done roundtables with young people. The young people tend to really love Dr. Fauci and kind of view him as almost like a grandfather. So he has been out there talking to young people. But we need to think of new creative ways. So we're trying to put vaccines into barbershops and to baseball games and NASCAR races. So any way that we can effectively distribute and administer the vaccines, we're going to do that. We're talking, of course, to the medical profession and pediatricians, the American Academy of Pediatrics, et cetera, and trying to expand access as much as we possibly can. But we're open to every and all idea.
Well, I hope we'll get some more today for you. I wanted to follow up on you were talking about the president's goal of reaching 70% by the 4th of July, and we're close to that, but the younger age group is holding us back, as you said. But really, the 70% isn't anywhere. I mean, ultimately, if we're going to achieve what's called herd immunity, which is where the whole population is, enough of the population is vaccinated so that the virus has a very hard time spreading. That's going to be higher than that. And I'm just curious, what ultimately is the administration's goal? Where do we need to be where do vaccination rates need to be? Ultimately, do we need to be at 80%, 90%, 94%, like for the measles? And as part of that, where does natural immunity come into this calculation? There's an unknown number of people who have been infected, but didn't have symptoms of COVID. And so how are you weighing all of that to know where we should be ultimately?
So you're correct. The 70% by July 4th was a marker. It didn't have biological meaning in itself. It was a goal and it was a marker. And we're going to be really close. It'll be probably later in July where we actually hit the 70%. I mean, I think that the goal is to get as many people vaccinated as possible, and also specifically to target those states, those counties and communities where the vaccination rates are 40% or 35%, because as we've been discussing, they're exceedingly vulnerable to something like the Delta variant. James might comment, but we don't really know what the herd immunity level is for COVID-19. I mean, as we know, this is a novel, meaning new coronavirus. And so it's only over time, probably in retrospect, that we'll know whether herd immunity is 85% or 92%, et cetera. So really, that just emphasizes how important our vaccination efforts are throughout the United States, and as Heidi was talking about, throughout the world. And we're absolutely concentrating on that. We also don't know how long natural immunity will last, and if natural immunity would protect against a potential variant that could develop, say, in another country, as both Heidi and James were discussing, which is why we want people to get the vaccine anyway to boost their immune response, even if they have had COVID-19 because we want their immune response to be as high as possible. We don't know if what we're going to do with boosters yet. I mean, those discussions are happening, like this week. I mean, they're happening every week now with our experts from the CDC and the FDA and NIH about, in a collaborative fashion about what we're going to do in terms of boosters, whether we would ask Moderna or Pfizer to change their product for boosters or go with the same product, whether we're going to do it at 9 months or 12 months, whether we're going to target specific populations such as seniors. So those discussions are happening right now. And as soon as we know anything, we'll let you know.
So Gideon, I just want to add two things to what Rachel said. The level of vaccination you need to achieve in the population to achieve herd immunity is related to the transmissibility of the virus in question. The reason why measles requires such a high level of vaccination is because it's one of the most highly transmissible viruses that we know. So if a variant arises that's much more highly transmissible than the current ones, the level of vaccination we need to achieve will also change, which is why we need to get everyone vaccinated now to deal with the enemy we know as opposed to the enemy we don't know. So that's a very important point to keep in mind, that herd immunity is related to the transmissibility of the virus. And if variants arise that are more highly transmissible, our goal will have to be higher than what we have currently. Just want to make
So James, just taking what we have right now, whichever one we looked at Delta or the original Wuhan variant, what is your estimate of what herd immunity would take at this point?
Well, based on the other viruses that I've studied, I would actually say that 80% would have been the goal for the original strains.
Okay.
Based on
obviously without the Delta. Interesting.
Yes.
Okay. So let me turn to Heidi and James and ask a couple of questions here. What advice would you have, and kind of turning more toward the vaccination, what advice would you have to the administration on how to get more people vaccinated? And I know that there's multiple different scenarios, and Heidi, I know you've spent years studying the reasons people don't get vaccinated around the world. What do you suggest to overcome the hesitancy? What works and what doesn't work from your perspective? And then I'll turn to James.
So,
Well, oh, go ahead, James.
no, Heidi, you're the you're the expert. My answer is always straightforward. It's trusted messengers. You need people who are trusted to be standing in front of engaging certain populations. And the one thing that we cannot get away from in our country is that mask wearing and being vaccinated has become politicized for some people. There are at least 2 studies I'm aware of that show that the best predictor of the lowest vaccine uptake is what % of the county voted for Donald Trump for president. So there's no getting around the fact we dealt with it with mask wearing. We dealt with it with the mitigation steps we tried to take. What we need are the messengers who those individuals trust to step up and start encouraging those individuals to save themselves, protect themselves in their communities. And we have to acknowledge that that is a problem. I mean, it's a serious problem. So from my perspective, it all comes down to who do people trust? The individuals and the organizations. They need to be mobilized in this effort. So that's my best answer to you on how.
And I know you've done an amazing job in Nashville and some of the outlying communities where Meharry, one of the traditionally all Black colleges, has been very, very influential. And congratulations on the work that you've done.
Well, thank you. Meharry is a very trusted organization here in Nashville and in Tennessee, and we tried to make sure we did our part to engage the communities that trusted us in terms of testing and vaccination. But I really think that's what it really comes down to: cultural humility and having trusted people and organizations engage communities in order to achieve success. So, Heidi.
You said it better than I could. I mean, trusted Trust is the holy grail. I mean, sometimes I say we shouldn't have vaccine uptake as our KPI, but trust. And if we focus on the trust building, it's going to have a knock-on effect in many positive ways. Because really, at the end of the day, it's about a relationship. And I think that, the other thing is it's going to affect other domains. And one of the wonders of COVID in terms of an opportunity for us is that it affects everybody. I mean, I don't think any of us have heard a number of people we interact with talk about vaccines, from your shopkeeper to taxi driver to your barber to your whoever, your Deliveroo guy, whatever. It's everybody. So it's a huge opportunity for us because it is a public-wide conversation. So we can, if people don't, for some reason, trust the health system, there's a lot of other options we have now with people who are somehow involved with vaccines that weren't before. And I think picking up on the trust mantra is trust is also a local, familiar, somebody that, if you take the vaccine, and we've seen this with other vaccine initiatives around the world, they want, and I remember in India, a group that everybody was, the other thing is we as a public health community sometimes make some assumptions without really talking to people. And we were assuming that this big bad rumor about sterilization was the big barrier. But when we actually asked a few more questions and sat with some of the people, what they didn't like was somebody coming from the big city, coming from Delhi and vaccinating and being a man. They wanted women and they wanted local women. So if something happened after their vaccination, they could go to them and they could say, look, this happened. What do I do now? So I think local is important. Listening to understand. We make also sometimes assumptions on who are the trusted figures. And a lot of times we face this with some of our work, trust building work around Ebola vaccination in Africa. You have your typical local leaders and hierarchies, and sometimes they're not the trusted ones, though. They're on the organogram as the local leader, but and oftentimes the ones who are the most outspoken are the least trusting, for the ones that will come to foreigners or to central bodies. So I think really understanding from local people who they trust but I think we also have to flip the coin over and think about it's not just getting the public to build trust, but also making ourselves trustworthy. And that's a huge issue because there have been some bumps in the road along the way where people have lost trust. And when sometimes a politician says something and then acts differently himself. We're facing that in the UK right now, but it happens everywhere. And, you need to rebuild trust then. And I think COVID for us is a huge opportunity for relationship building with the public around vaccines, getting to know. I've often said before COVID came along that immunization needs new friends. It is one of the most siloed vertical health interventions. And I worked a lot in AIDS before coming to vaccines. And I know, James, that's it's your beat too. And it's such a hugely diverse community who's was involved. And when I came into vaccines, I said, whoa, we're only talking to each other here. So COVID can really shake that up, and because we've got a lot of other areas of under vaccination right now, we could easily get major measles outbreaks, flu, who knows what's going to happen. So I think local trust, totally agree on that one. Think about building trustworthiness and don't assume what's in the minds of people. And don't forget that they can change.
Thanks, Heidi. I wanted to follow up with you and Rachel on a comment James made about the politicization of vaccination, along with mask wearing and other social distancing behaviors. But specifically with terms of vaccination, So how do we overcome this political polarization and you know, as James mentioned, the studies had found that the counties that voted for Trump are more likely not to not get vaccinated. Where, you know, if the person they trust is it, you know, it is not saying get vaccinated, in fact, is saying don't get vaccinated. How do we reach this population?
Well, thank you for that question. It's a challenge. I mean, I agree with James and Heidi completely on their comments. The politicalization of the whole COVID-19 response has led to more public health challenges, because at its heart, this is you know, our response to COVID-19 all around has been a public health issue, and it should not have become a political issue. Been used as a political football in the election in November, and then being used as a political football now. So I think that we get past that by finding trusted local messengers in those communities, as both James and Heidi were saying. And I mean, that's the purpose behind the president's coronavirus community corps, is to find trusted local messengers who are willing to stand up and talk about, as we've been discussing, the safety, the effectiveness, and the importance of the vaccination. So we are continuing to work on that. There is also a strong health equity component to our response. So we need to work past the vaccine hesitancy that we've been talking about, the political considerations, but then, you know, clearly COVID-19 has not impacted all communities the same. It has had a disproportionate impact on vulnerable communities that have had health disparities all along, including the African American community, the Hispanic community, the LGBTQ community, and others. So, you know, that is why we have our COVID-19 Health Equity Task Force, which will have specific recommendations to the president about how we're doing that. But we're not waiting for those recommendations. We're working on that. We're working on that right now. But getting to red states and convincing them about the vaccine and its importance is going to be a challenge, and we're going to continue to work on it.
Have you been able to enlist any of the local Republican leaders to really start to step up in that regard?
Yes and no. So we have in certain areas, in certain states, where community members, including political figures, have been able to do that. And in other states, that continues to be a challenge. So it's granular. It's going to be on the ground. As everyone was saying, there's no generalization I can give you.
Heidi, do you have anything to add on the politicization?
Well, yeah, I mean, we see a similar trend, and it's not quite as extreme as it is right now in the US, but we've been monitoring vaccine confidence across the EU for the last 5-6 years. And a political scientist at LSE took our data and layered it with populist opinion polling, voting behavior. And it was absolutely consistent across the then 28, now 27 EU countries, that those who were more prone to vote for populist parties were less confident in vaccines. They were more skeptical. It was absolutely consistent. It was really striking. I thought it was more in pockets, but anyway, that's a sidebar. But I totally agree with what Rachel and James is saying, reiterating the same point. But I think we need to find other things that people in these communities care about. And it's going to be different in different states, in different communities. You know, where there is a group of resistors for political reasons, I think that's where you really need time. You need listening time and understanding what else they care about. And I think one of the important things moving forward is also going to be contextualizing vaccines in the context of recovery, because there's been a lot of missed health opportunities because of COVID, because of the restrictions, because of people not, you know, because all eyes and work and focus was on, you know, reining in the COVID. So we've got a lot of health issues to catch up on. We've got a lot of mental health issues too. But I think by going into these communities, not even talking about vaccines at first, talking about what are your overall health needs? What do you feel like you need to get to the other side of this pandemic? What's been the hardest? And start with something that they care about. Politics aside, what's the most important thing to you in your community that you need support on? And if it's mental health, or if it's food, or if it's, whatever the issues are, issues around schooling, start there and then bring vaccines into that mix. But I think I think we've seen that that's really, you got to start where they are and work with that.
So let me follow up on that, which is really interesting. But is there another angle to it? The vast majority of people they work for other organizations. So what is the role of private companies or organizations or even universities in basically starting to say, we're going to require you to be vaccinated in order to either come and work here or to be a client of ours or a customer of ours or whatever? Is that an important angle?
I don't think that, I think the angle of companies is huge and a real important opportunity. I wouldn't start from saying, let's make it required. I'm doing more and more with companies because they have huge employee bases.
Right.
A lot of them, particularly if the international ones. So they've been coming to me, and where I always start with them is, let's understand what your employee base is thinking. And a bit of the same sense that I was just talking about with communities, try to engage with them to understand how have they been doing, how can we as a company support you. They want to be safe coming back to work, so start where they are and work with that. But I think as a community, we also see in a lot of surveys that actually employers are more trusted than sometimes political leaders or even their health. Maybe they have issues with health, but they trust their employers. So I think employers should come with an offer rather than a mandate. I think in certain situations, in certain settings, you might need to have a requirement because I worked for many years in the UN, and there was this fine line between your right to choice and when your right became a responsibility because you're putting other people at risk. And I think, if you're working in a daycare center or a hospital or a place where your choice could kill somebody else, then I think it's a reasonable time to bring in the conversation of a mandate, but not as a first step.
How about for you, James? How is that, in your work in the Nashville community? Have you been able to get employers to, kind of help in the vaccination process?
I think for a lot of employers, when the vaccine gets full approval, gets a BLA, they're going to feel more comfortable mandating it. Because, technically, it's still an EUA that these vaccines have, not full approval. But, we're a medical college, and our students and residents and physicians are interacting with patients. So we feel that we have to mandate the vaccines to protect the patients we care for. But I think for a lot of businesses, they're leery of mandating it until and unless one of the vaccines get full approval. So,
and when do you think that will occur?
I know that Pfizer and Moderna are preparing their packages to submit to the FDA for full approval, but I don't honestly know when that will happen. It may happen before the summer's over, but I really can't say.
Okay. And Rachel, to what extent are you working with employers to try and understand their needs and having them kind of be an advocate for vaccination, especially in the low vaccination areas?
I think it's a very important point, and the administration is working with business and with employers, which might be one of the tickets to influence vaccine hesitant states and communities, because the importance of business and the importance of the economy might be that common language that Heidi has been talking about to get past the politicalization that we were referring to. So I think companies and employers and business will be important allies because it's good for business for their workers to be protected so that they can work. It's good for business for customers to be vaccinated so that they can go out and buy things. And so all that makes it really, really important for continued economic growth. So I think that that's one common language. Whether we make it, whether businesses make it required, I mean, it's more likely right now to be hospitals and medical centers. And there was a recent court case in Texas that where they validated, the right of a hospital to require their employees to be vaccinated. In other businesses, it might legally get trickier. But I agree with James that I think a lot of that will come when the full authorization happens. Being an optimistic person, I think that will be in 2021. I can't tell you if it's going to be by August or October or whatever, but Moderna and Pfizer are preparing all those materials, and so it is going to happen in an incremental way.
I wanted to, we're going to move on to the Q&A shortly. So we already have a number of questions there, but before we do, I just wanted to go around quickly and ask everyone, what right now are the most important uncertainty or a couple of the most important uncertainties about COVID? James, you want to start?
So Gideon, I'm concerned that for long COVID or post-acute sequelae of COVID, that millions and millions of people who look like me, who are not taken seriously anyway when they go to the doctor, are now presenting with this amorphous set of symptoms, fatigue, headache, that looks like chronic fatigue syndrome, that they're not going to be able to get the care they need. And that's one of the things that I'm really concerned about. I mean, I just heard a story of a young, really accomplished Black woman. She's an assistant professor at a university in Texas. She got COVID in March. She's one of the earliest ones. She goes to the emergency room to try to get treatment, and they insist that she take drug tests because they assume that she has been taking drugs, that she couldn't possibly have long COVID. So I'm concerned that we make sure that those individuals who are brown and Black or poor, come from disadvantaged communities, can get the care they need, because there's tens of millions of them out there who are going to need it. And the bias that has been manifested in healthcare over many decades, we cannot let that get between them and the care they'll need. So that's one of my concerns, and I'm uncertain that will happen. But anyway, I think it's a major concern.
Rachel, what you're as someone in your position, so how prepared is the healthcare system to handle the chronic conditions that seem to be following COVID for many people?
I think it's going to be a significant,
particularly with mental health, I think, is a big area there.
I think all of that is going to be a significant challenge. As James was talking about, with the symptoms of long COVID being so variable and sometimes non-specific, that's a real challenge for the medical community and for physicians. You can use the example of what used to be called chronic fatigue syndrome, where it was very difficult to make it. And I saw tons of teens and young adults with those symptoms when I was at Penn State. That it's really challenging, and doctors, there's no test for it, and so it makes it really difficult in emergency departments, but even in doctors' offices, to be able to make a diagnosis and come up with a treatment plan. But you mentioned mental health, and that's exactly, Gideon, you read my mind, exactly what I was going to say otherwise, is that I think that we're going to see significant mental health challenges, and that includes, mental health like depression, anxiety, PTSD, but I'm going to put in substance use disorders and that as well as we come out of COVID. You can think of COVID as a generational trauma for young people. We tend to talk about ACEs, or adverse childhood experiences. This is the ACEs of all ACEs that has impacted our young people. And I think we're going to see significant mental health challenges. And The opioid crisis, which we used to talk about as the biggest medical crisis we faced, is not gone. In fact, more people in the 12-month period have died of overdoses in the United States, over 90,000 from the 12-month period of October 2019 to October 2020. Over 90,000 people died of drug overdoses. I think all of that remains for us and is going to continue. One of the new paradigms, which I think will be helpful, although not definitive, is going to be telemedicine. We've made a lot of progress in terms of telemedicine, and I think that hits a lot of health equity issues and will improve our ability to be able to deal with these issues, but they're going to be a challenge.
Heidi, what for you is the uncertainty that you're most concerned about?
Well, I mean, my husband had extremely serious COVID and hospitalization on oxygen, and I saw up close what long COVID looks like, in and out of hospitals, on steroid drips over the months, all kinds of different symptoms. But it's really, it goes on. And what's been interesting is to see how other people there's been this, people talk to each other about their long COVID, and then the conversations start opening up about the whole spectrum. So I think that somehow characterizing it in ways that I think getting back to what James was talking about, don't dismiss it. I mean, that if there's one thing that doesn't cost anything, is to get, everybody working in the health system or who is being approached by people with these symptoms, just empathy, empathy, empathy. We need it at so many levels in society right now. But right there, when they say, I'm feeling really bad, and, instead of saying it's drugs or it's in your head, or which there's a lot of, particularly when you're really stressed and a lot of people coming in, I think we need to acknowledge it. That already, I think Freud called it the talking cure, but just we need to build time in for that, because I think that's my biggest worry. My biggest worry is we're not going to flick a switch one day and say we're back to normal. There's a lot of work ahead. I mean, even with young children, we're seeing all kinds of things with anxieties. I mean, even 2-3 years old, they pick up what's going on. They know this is not normal. And they, new fears, anxieties, all kinds of things. So I think we've got a road ahead, and it's an opportunity for us if we work with it. Because even though I focus on a lot of negative stuff, I do that because I'm an optimist that we can turn some of this around.
Right. Thank you. So I think maybe we can turn now to some questions that have come up, both beforehand as well as during the session here. And I'll turn to you again, Heidi, and ask there's been a lot of press, obviously, about what's going on in India. And from your contacts in India and the like, what is going on there? And are they getting it under control?
Well, India already started with a less than perfect health system, but I think Delhi's calmed down a bit, but it's popping up in other areas. And also, the surveillance, what we're seeing, some of you may have read some of the stories about the bodies in the Ganges. These are people who can't afford to cremate. So you see upstream, villages just putting and so there's a different kind of, it's almost like anthropological surveillance, because what they're seeing doesn't line up with the numbers, but they are starting to get it under control in some settings. They are, when I was working in UNICEF, India was we procured, I would say, almost 60% of our global vaccine supplies from India. This is an example of a place that, we say it's all about getting local manufacturing. Well, India has some of the, not to say that countries shouldn't have manufacturing, but that got shut down because of borders due to COVID closed, getting not some of their ingredients, also people too sick to come to work. We don't factor in, I think, sometimes in our preparedness plans, scenarios that we like to assume that things will work, or that in your plans, like we're going to need X number of vaccines. We don't build in risk scenarios like, well, what if half the people can't come to work? What if we can't get some of the ingredients or the supplies that we need because of borders closing? Because these are all things that happen in pandemics. And I think India just played that out in a big way. I'm just concerned that there's another variant could emerge there. It's also going into Nepal. It's going into areas around. I think while they're getting it a little more under control locally, it's going global. And I think the other big message out of India, I'm on a Lancet commission on vaccines and therapeutics. And, we were saying, here we are focusing on vaccines and drugs, and we're not talking about oxygen. And that's pretty basic. And there's some really basic things that every hospital should have, COVID or no COVID. So I think that's been a really hard call for them. But again, I see companies weighing in. There's an example where companies are starting to take charge. They've been kind of getting separate facilities for their employees and tried to help, because the government can only do so much. And it was very clear it was stretched. India also has a politicization issue. There's a lot of particularly areas that just don't trust a strongly Hindu nationalist government. And we've seen this becoming more of an issue with vaccines in general. They're afraid that, that they don't want Muslims here, so we shouldn't take that vaccine. It's not everywhere, but that's coming up, we see in some populations. So politicization is, plays out in a number of ways, not unlike the US. Issues are different, but so it's complicated. It's one of the countries we do a lot of work in, and it's more like it's like a lot of countries in one, but yeah.
Thanks, Heidi. Here's a question from Adam Finkel, who says he's very frustrated as an industrial hygienist who understands that N95s and even face masks provide some protection for both the wearer and others, that the CDC has not made more clear whether or not vaccinated people can still present some risk to unvaccinated people they encounter. In other words, that they can still spread the infection even if you're vaccinated. And if the answer is yes, they can, why is there not more messaging about it's okay to wear a mask? And in fact, you might consider wearing a mask, particularly in areas where there's low rates of vaccination. Rachel, do you want to take that on?
Sure. So again, the chances of contracting COVID-19, even something like the Delta variant, if you are fully vaccinated, 2 doses of Pfizer or Moderna or 1 dose of Johnson & Johnson, is extremely unlikely. And so it's extremely unlikely that you would contract COVID. If that unlikely event happened, it's actually even more unlikely that you would be able to transmit COVID. So the decision was made by the CDC is that if you are fully vaccinated, that you could take your mask off. Now, you didn't have to take your mask off. And, we do want to make sure that message is clear. If you choose to wear a mask, that's absolutely fine. But you can take your mask off in public. You don't have to social distance, etc. But if you are unvaccinated, that you should continue to wear a mask. You should continue to social distance. You need to take all of those mitigation measures into effect. Of course, we don't have you have to rely upon the honor system, and that's a challenge. That's a challenge throughout the United States because there's no mask, there's no vaccination documentation that you have to give. So there is an honor system part of this, but I think it was important because the CDC was getting more and more questions about that to reassure people that if you were vaccinated, you can lead your lives, and also to serve as an incentive to people. See, if you get vaccinated, 2 doses of the mRNA vaccines or 1 dose of Johnson & Johnson, you can now go lead your life, and you can see your family and you can see your friends. And we need to, find continued motivation for people to get their vaccinations.
Okay. The next question I wanted to touch base on came from Nancy Danoff, who is a pediatrician in Seattle, asking about the status of clinical trials for kids under 12. And what's a realistic time frame for when they might be authorized for use? What precautions will help parents feel comfortable sending kids to in-person schooling? Maybe this is either Rachel or James. Maybe you guys can comment on that.
So I'll start. So I can't give you the date when the authorizations will come for either Pfizer or Moderna for pediatric populations. But I'm a pediatrician too, so I know how important it is. But they are coming. So I mean, those clinical trials are proceeding. It's hard to put a date on science. If I'm going to be, again, positive and optimistic, I'll be hopeful till by the end of 2021. It could end up being towards the beginning of 2022. It's not going to be, in August that those trials are completed. So they are forthcoming. We'll wait until the trials are completed, and then we're going to need to have a whole new vaccination effort to vaccinate children, which will be a challenge because I think that the parents are concerned and reluctant. We are seeing that now play out among teenagers. Of course, we have the Pfizer vaccine that has received its FDA EUA authorization for teens 12 through 17. Safe and effective and important. Moderna is cooking. And we had an initial uptake about to 30% of teens, but it has certainly plateaued. And actually, there's some articles out in the paper today about teens who want the vaccines, but their parents who are reluctant. So all that is playing out as we speak.
James, any thoughts on that from the vaccine advisory perspective?
No, I don't have anything to add. I will say that the VRPAC, the FDA committee, met a few weeks ago just to have an all-day long discussion about vaccines for children. And as Rachel said, we expect the trials to be concluded before the year is out. In fact, Meharry is participating in the Moderna trial for children. So we just have to wait for the data to come. It'll be evaluated because children are not little adults. So we got to make sure we do the trials, get the science before we make any decisions. So I think that's very important.
Here's a question from Dr. Michael Libman, who's an infectious disease specialist in Montreal. He asked whether, as local transmission declines, the spread by international travel, especially the variants, will become increasingly important. And many countries are doing routine surveillance of incoming travelers, but not the US. And he asked why this strategy has been essentially abandoned in the US.
Screening before you come into the U.S. with the number of people traveling to the United States in our interconnected world proved, even at the beginning of the pandemic, to be difficult at best and impossible at worst. If you think about the number of people who travel throughout our country, it's very difficult to do that and to be able to keep it up. You can try to have people screened before they come, and that could end up being necessary, but we're not implementing that at this time.
So, but that takes me back to a point that Heidi made earlier, how very important it is that we do our part to get the rest of the world vaccinated, right? That it's in our best interest as the United States to help the rest of the world get vaccinated. Waiting to get all of Africa vaccinated by the end of next year is totally unacceptable. We just can't let that happen. So
how do we do that faster, James?
I mean, I don't have the answer to that question. I'm just saying that it's really, really important that we figure it out and get it done. Because whether the variant of high consequence happens in Africa, Brazil, UK, wherever it happens, it's going to make it to the United States. That we know. So none of us are safe until all of us are safe. Okay, especially if we're not going to screen travelers coming to our country, then we darn better do our part to get the rest of the world vaccinated. That's all I'm saying.
To what extent has the administration kind of pushed it? I know we've had some offering of vaccines, Rachel, but I mean, are we doing enough?
Well, we have made some significant measures and contributions. The United States has committed to donating 500 million doses of Pfizer, which is the largest donation of any country. That was matched by the G7 partners with another 500 million. In total, the G7 Plus has committed 2.3 billion doses for the world. And so we will continue to share doses that we have and to encourage the companies to be able to be working with other companies to vaccinate the world. I agree how important it is. That is why the more and more vaccines that are available, the better. So, we have the Moderna and Pfizer vaccines, but we are going to be working to have Johnson & Johnson send vaccines to other countries in the world. The AstraZeneca vaccine is being used throughout the world. The new Novavax vaccine, it's not quite available yet, but that would offer a tremendous amount of advantages as well. The logistics are extremely complex of getting vaccines out to the world, but we are working through that. In fact, last week, doses landed in Mexico and Canada. On Saturday, yesterday, doses were shipped to Taiwan. We expect more shipments this week to Brazil. So we're doing everything we can.
Okay. And then I think the final question that I wanted to touch base on, which affects many of us, but Jonathan Kay was the one who kind of raised it, is it safe to travel internationally if you're vaccinated? And when do you think we're going to be able to start doing either business trips and or vacations internationally?
So I'm going to give you the same answer that I did as a pediatrician many years ago when I was a pediatrician in New York City at Mount Sinai and Lenox Hill. And a family would come to me with a child with an ear infection. And they would say, is it safe to go onto a plane? And I would say it depends upon how much risk you're having to take. Do I anticipate that your child's eardrum will rupture and that you're going to have a significant problem on the plane? No. Can I promise you that that's not going to happen? No. And so so it depends upon whether you want to be absolutely sure, then don't travel. If you're willing to take a reasonable amount of risk and I really think it's going to be fine, then you're okay. And I think it's exactly the same. I mean, if you are vaccinated with 2 doses of the mRNA vaccines, these vaccines are remarkable and you are very, very protected. Is it 100%? No. How important it is to travel and how much risk are you willing to take?
James or Heidi, anything else you want to add in on that?
No, I think that was extremely well said. It's really weighing the risks. And also, I think this past year and a half has made us learn how to do a lot more than we would have ever thought we could do without traveling. What's interesting is the London School of Hygiene and Tropical Medicine, where I'm based, we had 2 months before COVID hit already started moving into more Zoom-based type communication and infrastructure, because we have a very strong climate group that was insisting that we reduce the total travel time of the school for environmental reasons. So we had a bit of an edge there, but I do think that, we've learned to kind of think about what is really crucial travel. I mean, what is, and I think we're going to have to make those most judgments, as Rachel said. You just don't know once you get on that plane.
James, anything else you want to add to that?
No, I don't have anything. I agree completely with Rachel, what she said, but also just thinking about where you're traveling to, and
Yeah.
that local
Yeah.
situation is very important.
With one last question from our audience, we've had a number of questions about cardiac inflammation as a side effect of some of the vaccines, and this has been particularly seen in younger people. And so can you just, I don't know if James and Rachel, if you can just quickly talk about how, I think that the general tenor of the question is how worried should kids, young people be, and how much of an obstacle is that to your efforts to get, the under 26 group vaccinated? And particularly then as we move into younger kids.
So we've been looking at that very, very closely with the CDC, the FDA, and the NIH. So, there is a signal in terms of myocarditis or an inflammation of the heart with the mRNA vaccines. It is extremely rare. And the myocarditis has been extremely mild. So it's different with other young people who might have myocarditis due to an infection, which you can get this type of year, infection with viruses called enteroviruses, where it can be very severe and lead to illness and hospitalization. What we saw were exceedingly mild. And sometimes only picked up because, a young person might have some chest discomfort. And as opposed to saying, we'll see how it is in several days, that the young person would be taken to the emergency department. They would have a cardiac evaluation with an EKG and echo and a cardiac MRI and blood tests, and show a little bit of inflammation. And then with either no treatment or relatively mild treatment, it was better in a week or two. So we strongly feel that this should not be an impediment to immunizations in young people, 12 through 17, and then 17 through 18 through 26. And we came out with a statement with not only the federal government, but actually, the American Academy of Pediatrics, the AMA, a whole host of medical and public health authorities saying the same thing, that it is very, very important for these young people to be vaccinated. It was seen a little bit more in males than in females, but it's rare and it's mild, and the young people should be vaccinated.
Thanks very much, Rachel. So to conclude our panel, I want to ask for about a call to action for our, for the listeners. I think a lot of people want to know, what can I do to help to fight the pandemic? And beyond getting vaccinated and wearing, should the variants get worse than us, and wearing masks again, or et cetera, beyond the individual things you can do, I think there's an interest in knowing what are the policies or actions that people should be advocating for in their states and local communities, as well as the federal level, to bring this pandemic to an end and to keep us from making the same mistakes with the next pandemic. So I don't know who wants to start with that.
That's a short question.
Heidi, do you want to start?
Oh, it was a big one. So I think I would just come back to something I was saying earlier is, one, the importance of localness is, we've learned how valuable that is. So wherever you live, wherever you work, look around. If you want to do something tangible that has impact, I think the first thing to do is get to know what the issues are locally, either in the state level, in a business level, and then, to the extent that where you can leverage, because everyone can bring different things to this story. So I would start there. It's more tangible, and also we really, one of the recommendations I made in another context was that we should in our preparedness moving forward for the next one, which there will be more, we really need to think not just at national level preparedness, but we need to recognize that we cannot rely on, and this is a global issue, not just in the US, that have scenarios which don't depend on political leaders, that are local, state level, regional, district, that preparedness is very much owned and ready at a local level to the extent that you can. You may have a great visionary local leader and you may not, national leader, but we've seen around the world that the most important traction we've gotten in a lot of stages is local. So I would look around where you live, where you work, and see what you can do to make a difference.
I agree totally with Heidi, but I would remind the listeners or the people that have tuned in that it's the same song with a different melody. HIV was noted to be a problem first in this country in 1981. President Reagan did not mention it publicly until 1987 because it was thought to be a disease that affected only gay men. And because of the social construct of the time, where there was, it was thought that if you were homosexual, you were sinning or whatever. My point is, we played that same song again with a different melody, this time by having national leadership that allowed politics to supplant science. We cannot let that happen again, okay? And I think we lucked out in some ways with this coronavirus. Imagine if this coronavirus had the same fatality rate as HIV did at first. Oh my God. Think about that for a moment. So what I'm suggesting is that wherever you are, whoever your leaders may or may not be, local, otherwise, we cannot let politics supplant science in responding to a public health crisis. We just cannot let that happen. And I'm going to leave it at that.
Well, thank you for the opportunity to be on the panel. It's been great. I think one of the important lessons of COVID-19 is how interconnected we all are. We are all interconnected. What one person does influences their family, influences their community, influences their state, our nation, and the world. And so the level of personal responsibility that people have, I think, is critical because it really does go out like pebbles, if you throw a pebble in a lake. I think the other is the importance of public health. Public health traditionally has been underfunded compared to other medical issues and medical centers and medical research. And this is public health at the local level, the state level, the national level, and the international level, because again, we're all interconnected. And we need to have sustainable funding for public health for our workforce, for our IT and data capabilities, and to be able to prepare for the next pandemic. Because as Heidi said, the next pandemic will be coming, and the decisions that each person makes is so important. So my call to action right now would be, please, if you have not been vaccinated, don't wait and get vaccinated tomorrow. And then make sure that you finish whatever course there is to be protected. And to do that, not only for yourself, but for your family and your community, and really for our entire nation. But to do more, this is the Harvard Radcliffe class of 1979. You are the social influences. You are the trusted community members that we're looking for to speak about the safety, the effectiveness, and the importance of the vaccines in your community. So please speak up, speak out, and help us get rid of COVID-19.
Amen.
Thank you so much, Rachel, James, Heidi, my fellow moderator, Gilad. It's been a wonderful panel. And now I'm going to turn it back over to Dorian.
And I would also like to add my sincere thanks for all that you guys are doing and for certainly participating on the panel. It's really been wonderful to see such an amazing involvement from our classmates. So thank you.
These are national, global experts who shared their expertise with us. And there are a lot of you in the audience who are equally skillful and knowledgeable. Let us know. Today, Achieving Change Together became Addressing COVID Together. So as African-American with pre-existing conditions down here in Louisiana who travel to Texas, I know my risks are high. So I have a personal interest in fixing this mess or doing what I can to do it. I want to thank the panelists, the moderators. I want to thank their staff and teams for working with us. And special thanks to Nini Cohen, who passionately, relentlessly, and tirelessly put this whole program together. On your screen are our website and email addresses. Give us ideas of future things you want to do. Look forward to us update on this in the fall because this is still a moving target. And that's it.